morning to all of you, and good afternoon and good evening to all others who are logged in from rest part of the world. Today, our guest speaker for the day is Professor Dr. Reena Nair from Kolkata, and she's going to lecture us on treating lymphomas in India in the era of Polatuzumab and Brentuximab Vedotin. This webinar is brought to you by Mumbai Hematology Group, supported by Perfect Square. I thank Mr. Yash, Mr. Kalpesh, and the team Perfect Square, Executive Committee of Mumbai Hematology Group. Our chief guest for the day, Colonel Dr. Kundan Mishra from Lucknow. Our guest speaker for the day, Dr. Reena Nair from Kolkata. All our discussants were themselves very eminent hematologists and medical oncologists, and you participants for spending the Sunday morning, afternoon, and evening from whichever part of the world you're logged in. Let me give a flavor of our next weekend activities. Next Saturday, that is 6th of April 2024, from 7 p.m. Indian Standard Time onwards, we have Professor Gerald Friedrich from Washington, US, speaking to us on asciminib-based treatment of CML. And following day, that is Sunday, 7th of April 2024, from Indian Standard Time 11:30 a.m. onwards, we have Professor Andrew Davis from Southampton, UK, speaking to us on how do I manage follicular lymphoma in 2024. Let me introduce our discussions for the day, and here displayed in alphabetical order. To start with, we have Dr. Aditi Shah from HCG Hospital, Borivali, Dr. Aditya Jandial from Homi Bhabha Cancer Hospital and Research Center, Mulanpur, Chandigarh, Punjab, Dr. Amrit Kaur Keller from Kokilaben Dhirubhai Ambani Hospital, Mumbai, Dr. Ankur Ahuja from AFMC, Pune, Dr. Chandrakant MV from Narayan Hospital and Arun Tagore Hospital, Kolkata, Dr. Deep Gala from SGPJ, Lucknow, Dr. Dinesh Burani from Rajiv Gandhi Cancer Institute and Research Center, New Delhi, Dr. Ganesh Jeshetwar from Yashoda Hospital, Hyderabad, Dr. Hari Menon from St. John's Medical College Hospital, Bengaluru, Dr. Jeevan Kumar Garg from Tata Medical Center, Kolkata, Professor Dr. M. Joseph John from Christian Medical College, Ludhiana, Dr. Narendra Agrawal from Rajiv Gandhi Cancer Institute, New Delhi, Dr. P.K. Sasidharan from Government Medical College, Kozhikode, Colonel Dr. P. Suresh from RNR Army Hospital, Delhi, Dr. Pawan Kumar Singh from BLK Max Super Specialty Hospital, Delhi, Dr. Pritish Chandra Patra from SOA University, Bhubaneswar, Colonel Dr. Rajan Kapoor from RNR Army Hospital, Delhi, Dr. Sadashivadu Gundeti from Nizam's Institute of Medical Sciences, Hyderabad, Telangana. Now it's a time to introduce our chief guest and very special guest of the day. We have with us Colonel Dr. Kundan Mishra from Lucknow. Colonel Dr. Kundan Mishra is MD, DNB, MNAMS, PGDHHM, PGDCR, and DM Clinical Hematology. Currently Professor in Medicine and Head Clinical Hematology and Stem Cell Transplant at Kaman Hospital, Lucknow. It's my privilege to invite Colonel Dr. Kundan Mishra to inaugurate our webinar and give some words of wisdom. Over to you, Dr. Kundan Mishra.
Good morning, everybody, and thank you, Dr. Amit, for introducing me. It's really a privilege to say a few words in front of some of the stalwarts of hematology in India, including many of my teachers with whom I have personal relationship and learned quite a lot. Rather, I'm still learning. And talking about lymphoma, I think Reena, there's nobody better than Reena ma'am to talk about lymphoma. So I'll talk something else. I was just trying to search that what we have done so far as far as Polatuzumab or Brentuximab is concerned. So I just went back in time. So on PubMed, I was searching lymphoma and India. So when I am searching lymphoma in India, I got about 6,000 publications over there. Out of that, more than 50%, that is 3,569 are in last 10 years. So in last 60 years, we may not have done much, but in last 10 years, as far as publications of data is concerned, we are doing quite good. But still, perhaps we are lagging behind. As I went further and I tried to check for that how many publications we have in Brentuximab, and I noticed that there are hardly 1,006. There are around 1,564 publications on Brentuximab overall from the world in last few years since it has been there. And from India, we have publication in single digit. Similarly, for Polatuzumab, There are around 200 publications worldwide, and we have got a single publication till now. And that too, there are 10 patients, one publication including 10 patients. So that is what is being shown on PubMed. So one thing is that we need to work little more as far as publications are concerned. These days, I am handling a couple of journals, so I mostly talk in terms of publications. Maybe it may not be that very appropriate for many of you, but most of you will agree with me that whenever we start talking on any topic, it's better that we talk about what we have done so far. And that is only possible when we collect our data, analyze it, and publish it. As far as Reena ma'am is concerned, I noticed that one of the earliest, if I talk about DLBCL and India, there are around 250 publications. And I was noticing that one of the earliest publication is by Reena ma'am on PubMed. It was, I think, lymphoma in HIV, and then one tonsillar lymphoma more than 20 years back or so. So ma'am has been a pioneer, not just in treating, but publishing also. And I hope that in future, we'll get some article on this recent advances also from ma'am and her institute, no doubt. So one thing is about that when we are using this, these days we are using quite a lot of Brentuximab and Polatuzumab. So if we are using it, we must collect data and try to analyze it and publish it as soon as possible, as much as possible. Publish or perish or publish and flourish, those items are okay, but I think it has some basis also. These are not baseless things just for the sake of saying. These are important things. We are identified in present world. We are identified by what we have published, and when we start talking, people expect from us to show our own data. So it will be very important. So hematology is a growing branch thanks to the medical oncology and other supportive branch who have been thriving or who have been helping us in distribution of our workload. There is huge workload of clinical hematology, whether benign or malignant in India, and our number of hematologists, hemato-oncologists are relatively very less. So there are a scope of getting more and more colleagues in this field, and all of us should combine. We should make consortium as are being made these days for leukemias and even aplastic anemia. I noticed last time there is something we have got new, and similar things are there for hemophilias, thalassemias. So in the time to come, perhaps we should unite together and collect data on these newer drugs also and try to analyze it and publish it. That is one thing I feel like. Second thing is that lymphomas treatment in last 20 years has been almost static. Ms. Chop was there for many years. Then we got rituximab. And once we got generic rituximab, I think somewhere around 2007, if I'm right, Dr. Reddy was the one who got the generic rituximab. Since then, we have been using quite a lot that arch of for DLBCL, and there has been some kind of, I'll say, static kind of feelings in last close to 2 decades that not nothing extra we are doing for these patients. So with neo drugs in action now, I think it seems to be as if the response is going to be better, particularly in patients who relapse. Blinatumomab has shown to be much more effective than any other drug. As far as Hodgkin's are concerned, from Hodgkin's lymphoma, we have already changed the name to Hodgkin's disease. That has been the effect of ABVD in the field of Hodgkin's lymphoma management. So with another drug in the form of Brentuximab, and even sometimes we are using checkpoint inhibitors also. So overall, in Hodgkin's lymphoma or Hodgkin's disease, what we call these days, things are looking even brighter. So how to go about the disease treatment and all that, ma'am will share the data and the outcome of the disease. What I'll say that things are looking quite bright. Things are looking quite bright. All of us together should now aim for early diagnosis and treatment of the patients wherever the patients are. We should try to treat patients now at various centers. We should encourage our junior colleagues to treat the patients in periphery also. It should not happen that in a handful of metropolitan cities only these patients are being treated. We should encourage our junior colleagues who are now going to even a smaller city, tier 2 city and tier 3 cities. We should help them out. We who are sitting in, not me right now, but my seniors and all discussants and all who are sitting in metropolitan cities, I look forward for them that they help people who are in tier 2 and tier 3 to keep doing good jobs. They should be encouraged to treat patients over there. And overall, I feel that the future of hematology, hemato-oncology is bright due to good people in this field as well as due to the newer drugs which are coming. That's it from my side. Over to Reena ma'am for her talk. Thank you.
Thank you, Dr. Kundan Mishra, for that really great words of honor and words of wisdom. I now share the screen again. So now it's a time to introduce our guest speaker for the day. We have with us Dr. Reena Nair from Kolkata. Dr. Reena Nair is Senior Consultant, Clinical Hematology, Head, Department of Medical Oncology at Tata Medical Center, Kolkata. She did MBBS and MD Internal Medicine from Goa Medical College under Bombay University way back in 1979 to 1988, Residency 1988-89 and Fellowship 1991-1994 in Medical Oncology at Tata Memorial Hospital, Mumbai. She was a faculty from lecturer to professor in the Department of Medical Oncology at Tata Memorial Hospital from 1994 to 2012. She has been the principal investigator in 35 clinical trials, investigator-initiated as well as industry-sponsored trials. She has been the executive committee member and faculty at Australia and Asia Pacific Clinical Oncology Research Development Accord Workshop in the year 2010 to 2018. She has been the international scientific advisor to the Lancet Hematology in the year 2020 to 2022, guest editor Lymphoma Outcomes from India for Frontiers in Oncology from 2021 to 2022. She has been the editor, Management of Hematological Malignancies in the LICS for Frontiers in Oncology 2022 to 2023. She has published over 125 papers and 15 book chapters. Her current interest is management of hematological malignancies with special interest in lymphomas. She has been the founding member of the National Myeloma Group, that is IMAGE, from 2017 till date. She has been the principal investigator of OncoCollect Lymphoma Registry from 2018 till date. She has been the founding member of the Immuno-Oncology Society of India from 2019 till date. She is also the founding member of the Women for Oncology India Forum 2021 till date. She has received various awards and honors, to name a few: Inspiring Oncologist Award 2020 on Doctors' Day Conclave, Economic Times; Aparajita Saluting Womanhood 2021 10th Annual Awards; Indian Society of Medical and Pediatric Oncology Oration 2022. And today she is with us and she is going to lecture us on treating lymphoma in India in the era of Polatuzumab and Brentuximab Vedotin. Well, thank you so much. Over to you, Professor Dr. Reena Nair, ma'am.
Thank you, Amit, for those very elaborate but kind words. So I will share my screen and then we'll begin the discussion for today. So I will take this opportunity to okay, can you see my slides and is it in the
full screen? Now it's okay. Perfect.
okay. All right.
Yeah.
So I will take this opportunity to say that I have turned the topic a little bit around. I will discuss Brentuximab, Vedotin first, and then followed by Polatuzumab. The reason being that Hodgkin's has been a rather easy disease to tame. In DLBCL, we will have lots further discussions to take over after I finish my talk. I have many disclosures, but the main disclosure would be I have not much work done in this area. And so I have borrowed extensively from slides which I used for the advisory board for Roche Pharma India, as well as for Takeda. So a lot of it is theoretical discussion today. But among the papers that were mentioned, a few are from our center, and I will try to show you the data. Never mind that it is only in 10 patients. So we'll begin with Hodgkin's lymphoma, and our aim is to discuss beyond chemotherapy. And for a disease where we have such high cure rates, the first question that comes to mind is there a need to move beyond chemotherapy, especially considering that it's so easily available, it's reasonable, and we have years of experience in managing the toxicities of patients who come for treatment with Hodgkin's. We now begin to look at competing risks to cure, and we can afford to do that because we have available choices. So I will first present a typical case of a young female patient with Hodgkin's lymphoma. We'll discuss what are the kind of upfront combinations that are available for such a patient. We will also discuss targeted therapies, Brentuximab being the talk of today, along with combinations with the checkpoint inhibitors, which is making a difference in the outcomes of Hodgkin's lymphoma. And with a little bit of time, perhaps also discuss targeted therapy in combinations with chemotherapy for relapsed refractory Hodgkin's lymphoma. After that, I will touch upon diffuse large B-cell lymphoma and discuss Polatuzumab. I will avoid discussion on T-cell lymphomas and Brentuximab, but we can always take that up during the discussion. So let's look at our own data. Overall survival for Hodgkin's lymphoma, 5 years, is somewhere around 80% for all stages. The event-free survival for the same almost 1,000 patients is at 72%. And so do we really need to change something that we have come so far in? This is a multi-center registry from India, which we published about 2 years back. These are all patients enrolled in this registry between January 2011 to December 2017 and were followed up till December 2020. We had over 1,000 adult Hodgkin's lymphoma patients, of which almost 1,000 were treatment naive. And for this paper, we have presented the results of our treatment naive patients. If we look around, perhaps the world is a wee bit better than us. 90% of patients are cured with first-line therapy. In early stage, it is 90 to 95%. And in the advanced stages also, it is well above 85%. And more than 85% of these patients are alive at 10 years. So why this itch to change? More recently, we have been seeing that deaths from other causes than Hodgkin's lymphoma are becoming a problem in patients who were treated for Hodgkin's disease when they were young. And so disease control and survival does not now mean the same thing. And hence, we have begun to question our old chemotherapy and radiation being superseded by new agents. And of course, we can make these questions now because we have agents available. So typically, a young 25-year-old lady presenting with cough and breathlessness, no B symptoms, had a mediastinal mass on the X-ray, 5 to 6 centimeters, or she could have presented with a mass which is more than 10 centimeters, putting her either in early stage or in the advanced stage disease. Core biopsy typically shows classical Hodgkin's lymphoma. What are the treatment approaches? What are the outcomes of these treatment approaches? And what are the competing risk factors? If we consider as early stage and we look at the overall survival of patients who are treated for Hodgkin's lymphoma with a mediastinal mass, the 3-year and the 5-year overall survival is almost somewhere between 98 and 100%, depending on which group and which trial we take. So the results for such a patient are excellent. Possible treatments which have been offered in these trials include the ABVD 4 cycles, de-escalated cycles of therapy, but a large radiotherapy field. This was the HD11 trial. Then we had trials which de-escalated after the PET was negative and removed bleomycin and avoided radiotherapy. There always was a doubt of false negative PET scans, and avoiding radiotherapy was always in the mind whether the treatment is complete or not. But again, I've shown you the results. They were to the overall survival was fantastic because we always had a second line treatment for these patients. We used escalated BACOP and reduced it to ABVD and avoided radiotherapy if the PET was negative. But when we use escalated BACOP in young patients, which has been the standard of the German Hodgkin study group, there has always been a concern about fertility in these young patients. More recently, we have Brentuximab AVD, removing bleomycin, which is such a pleasure because invariably once a year we did lose a patient in complete remission to bleomycin toxicity for a large many years when we were using bleomycin in all 6 cycles. Again, over here, if the PET is negative, we can also avoid radiotherapy. So we avoid bleo and we avoid radiotherapy. The follow-ups are short-term, and we are still looking for the results of randomized trials in early disease Hodgkin's lymphoma. We have checkpoint inhibitors used in a similar manner. And if the PET2 is negative, we can avoid radiotherapy. But the problem for checkpoints is the same. The follow-up is short, and we still look for large randomized trials. So invariably, we have a lot of choices, but each of these choices comes with risks. So the short-term risk for all chemotherapy trials is myelosuppression. For the long term, we worry about second cancers, we worry about cardiac disease from the radiotherapy field. When we use extensive chemotherapy with great results, we worry about young patients and their future fertility. Fibrosis is a thing of the past now, with bleomycin almost going out of our treatment paradigm or being reduced to only 2 cycles. Neuropathy is a new concern which remains with all, not only the old drugs, but the new ones also. And of course, for patients who fail, the need for a second line is always there. I said we can dream now because we have drugs available. And for today's discussion, we will discuss Brentuximab vedotin, which is an anti-CD30 molecule. And we will also discuss checkpoint inhibitors because they go hand in Hodgkin's lymphoma. So if we look at the upfront novel agents that are available in combination with chemotherapy, then the first phase 2 trial was done using sequential pembrolizumab and AVD for newly diagnosed patients of Hodgkin's lymphoma. The first trial was in 30 patients. They had early unfavorable stage patients as well as advanced stage patients. And what they did was gave 3 cycles of pembrolizumab, which was followed by ABVD, and the response was assessed after pembrolizumab, after AVD, and at the end of treatment. And if we look at the response rates, then about 37% of the patients go into response with monotherapy itself. By the time we give another 2 cycles of AVD, 100% of the patients show a PET response. And at the end of treatment, whether you give 4 cycles or you give 6 cycles to complete the treatment, the response rates remain at 100%. This is the long-term follow-up at 33 months of the same patients treated sequentially. And this curve is completely horizontal, something that we had never ever seen in any malignancies before this. It remains at 100% even at 3 years. This is one similar patient from this group of patients treated, like the one that I presented, a large mediastinal mass. Response to single agent pembrolizumab was a complete response on PET scan. And of course, all these patients have remained in remission. There is another similar study, which is concurrent pembrolizumab with AVD. Again, 30 patients treated, complete response in 90 patients, overall response in 100% of the patients. With the median of 2 years, the overall survival is at 100% and the progression-free survival is at 97%. So these were small studies, but it gave us an idea of the way things were going. We were at least able to get rid of bleomycin and effectively get away from radiotherapy as well. The first proof of principle comes from the Echelon study, which is a phase 3 study, where in a 1:1 randomization, Hodgkin's lymphoma patients, over 1,000 of them were randomized to ABVD as the standard arm versus Brentuximab AVD. They received 6 cycles. The first endpoint was the progression-free survival, and the key secondary endpoint was the overall survival. At 6 years of follow-up, there is a difference which is statistically significant, and the median follow-up of this trial now is 73 months. And so this is another way of treating our patients of stage 3 and stage 4, staying away from bleomycin, staying away from radiotherapy with long-term results which are better than standard ABVD. And if we look at the reduction in the risk of progression or death, AAVD reduces this by 32% as compared to ABVD, which was the standard. This is also one of the trials which has shown at 6 years a difference in the overall survival, which is statistically significant. And AAVD significantly improved OS with a 41% reduction in the risk of death compared with ABVD. So definitely there is something about AVD which we cannot ignore in today's world. Shortly after that, we had the next trial, which is the SWOG trial, which actually looked at AAVD as the standard arm and looked at what nivolumab with AVD does. And in a short term follow-up, at least the initial progression-free survival suggests that Nivo has an impact, and maybe and it shows a 6% difference at 1 year. We await the long-term results of this trial before we begin to decide which is the better of the two. If we look at the discontinuations and the adverse events, there's nothing very much to choose except to say that Brentuximab has a little more peripheral neuropathy. And in the Nivo arm, growth factors were not given to all patients. And hence, the neutropenia was slightly more as compared to Brentuximab, where it has become mandatory to support these patients with growth factors. Again, if you look at subgroup analysis, then the elderly patients seem to tolerate Nivo better. And in the very early results, it appears that they even do better as far as progression-free survival is concerned at 1 year. So going forward, can we reduce chemotherapy? And, this is kind of a move towards chemo-free regimens, which is a dream of all hematologists and medical oncologists. So if we now get rid of one more chemotherapeutic drug and put Brentuximab and Nivo along with Adriamycin and DTIC, what would be the outcomes? So this is a small single-arm trial. It is a phase 2 trial, which put these 4 drugs together in a 28-day cycle, and patients have been followed up for 5 years. Their primary endpoint was response. And the efficacy analysis is extremely encouraging, with overall responses at 93% and complete responses at 88%. And most of these patients, 94% of them, have a duration of remission that is now over 12 months. And the safety profile also gives us definite indication that there is no febrile neutropenia if you treat these patients with enough growth factors, and there is no death on treatment. This is one more regimen which reduces chemotherapy further, but of course at an extremely great cost. So slowly but steadily we move from the standard chemotherapeutic regimens to, at the moment, targeted therapy with reduction or omission of chemotherapeutic drugs in a move to go towards chemo-free treatments in the future. Like I said, presently at this moment, it is at escalated costs, but in future, we hope to reduce long-term toxicities and maintain high cure rates using these drugs. If we look at the relapsed refractory setting, conventional salvage therapies have given a reasonable overall response in the range of 60 to 85%. But the complete response rates, which is a surrogate to the outcomes of these patients, has been in the range of 20 to 40%. If we look at novel combinations, either together or with chemotherapy, Then in the third column, you will see that PET negativity is to the tune of anywhere between 70 and 80%. So we have more than doubled the complete response rate, which is the first surrogate to outcomes of patients receiving salvage. If you look at single agent activity of Brentuximab, it is almost like combination chemotherapy. Overall response rate of 75% and a complete response rate of 34%. And it is similar for pembrolizumab, which was the first checkpoint inhibitor. Nivo has been used in patients after Brentuximab and also in patients who had Brentuximab and autotransplant. And again, over here, we see that the overall response rate is almost as good as many of the combination chemotherapies which we have used in the past. Is there a debate about which targeted therapy is best? And that is addressed by Keynote 205, in which they randomized Brentuximab to pembrolizumab in relapsed refractory Hodgkin's disease. But note that many of the patients who were randomized were exposed to Brentuximab before they were put on this trial. And so there is a statistically significant difference in the outcome of pembrolizumab as compared to Brentuximab. But I think a neater, cleaner trial would be where all patients were naive. We look at the toxicities, and most of these toxicities can be taken care of by prophylactic use of growth factors. And Brentuximab doses may need reduction because of peripheral neuropathy. Let's come to using these two agents together. This is again in relapsed refractory Hodgkin's lymphoma, where in 100 patients, they have used both the drugs together, and the overall response is 85%, and the complete response rates as to the tune of almost 67%, which is extremely encouraging considering we have no chemotherapeutic drugs over here. And if we look at the 3-year outcome of these patients, then it's 77% for relapsed refractory patients treated with only these two drugs. For those who undergo consolidation with high-dose chemotherapy and a stem cell transplant, the outcomes are 91%, much better than what I showed you for our treatment-naive patients. So definitely, if it does so much in relapsed refractory disease, it has a long way to go coming into the front line. If we look at the 3-year progression-free survival for patients who had relapsed Hodgkin's lymphoma, it is at 90%. And for primary refractory Hodgkin's lymphoma, where we sometimes give up early, the outcomes are 61%, and that is almost equal for many years to the outcomes of stage 3 and 4 patients treated upfront for Hodgkin's lymphoma. This is the overall survival, again, more than 90%, and for patients who are relapsed refractory. In combination with chemotherapy in the relapsed refractory setting, we used Brentuximab Vedotin with bendamustine as a bridge to transplant, because by itself it was very expensive when it first came in for use in our patients. We have used it in 30 patients out of the 179 relapsed refractory Hodgkin's lymphoma during the same period of time. And this is mainly due to cost constraints. 57% of these patients underwent autologous bone marrow transplant, and we had a reasonable number of patients undergoing allogenic transplants. At 5 years, we feel comfortable to say that what we did at that time was right, and we have quite a few patients who are now on the plateau and long-term survivors after this bridge transplant. If we look at other trials of checkpoint inhibitors with chemotherapy for relapsed refractory lymphoma, again, the outcomes, overall response rates are to the tune of 100%, complete responses 92%, and an almost near horizontal curve when we use checkpoint inhibitors with pembrolizumab. And similarly, if we use it with ICE, which is something that we do commonly for all relapsed patients, the estimated 2-year progression-free survival is 87% and overall survival is 95%. So these survival curves is what I had shown you for early stage disease with all the trials that were available in the world with chemotherapy drugs. we are now seeing the same kind of survival curves for relapsed refractory Hodgkin's disease. In maintenance, the Athera trial was published quite some time back, and its 5-year follow-up suggests that the benefit of using Brentuximab as a maintenance therapy continues to be effective even at 5 years, and the progression-free survival is 59% versus 41% for those who are not given maintenance. So in Hodgkin's disease, I think there is no doubt that these drugs have come in. Presently, they are expensive, but as costs come down, we will definitely be using more and more of them. And as the data matures and we become comfortable that they don't increase second malignancies and all the other competing risk factors of chemotherapy for Hodgkin's lymphoma, they will become a standard of care. And then sometimes I worry to think that the new students will look at my old papers and wonder what I was doing during the years that I have been treating lymphomas. Next, we'll switch to DLBCL, and we have a lot of anti-lymphoma agents available for DLBCL. And this is a much more heterogeneous kind of a disease. If we look at our outcomes, we have made differences when we started with CHOP-like chemotherapies. The biosimilar rituximabs no doubt have helped us greatly in managing our patients. And this again is a real world outcome data from 29 centers in India with over 1,300 patients of DLBCL receiving CHOP or CHOP-like therapies, and all have received rituximab. And if we look at the overall responses, it's at 90%. If we look at the progression-free survival across stages, it is 69%. And the overall response at 2 years is 80%. Of course, this is early results just published recently. But this is the baseline from where we start DLBCLs. R-CHOP does not cure many DLBCL subgroups, and that is no surprise. We have all been struggling with patients who come with high IPI, with patients who cannot take full doses of R-CHOP, with the non-GCB phenotype, especially uh, the dual protein expression, as well as the double hit, and sometimes the triple hit lymphomas. And so this is a whole bag full of many different diseases which come under DLBCL. Over the last 20 years after R-CHOP became the standard, we have had many randomized trials trying all kinds of approaches. And basically, we failed to improve the results of R-CHOP by any of the plans that we had, whether it was enhancing the anti-CD20, using targeted therapies along with standard R-CHOP, increasing, intensifying chemotherapy, or using any kind of maintenance. So the first breakthrough that has happened after 20 years is the publication of the results of POLA-R-CHP versus R-CHOP. And following that, in 2022, the European Commission approved Polatuzumab in the treatment of DLBCLs for the first line. And more recently, in 2023, it got the approval of FDA as well as the DCGI, and now it is approved in India as well. So what is this very famous POLARIX study? It is a combination of Polatuzumab along with R-CHP, which is compared in a 1:1 randomization to R-CHOP. And these are all previously untreated DLBCL patients who were not the very early stage disease. So they were IPI 2 versus 3 and 5. They had bulky diseases and they had stages which was a little more than the very early stage disease. They were all given 6 cycles followed by 2 cycles of rituximab. And in the first outcome presentation, at the end of 24 months, there was a 6% difference in the progression-free survival of patients receiving Polatuzumab, and this was statistically significant. In a more recent update of the outcome analysis at almost 40 months, this difference is maintained and maybe slightly improved as well. And the event-free survival also was statistically significantly better for patients receiving Polatuzumab. What was a little disappointing was the overall survival did not show any difference in the outcomes of the two groups of patients. If we look at the various subgroups, one thing is for certain that the arm that received Pola with RCHP required much less subsequent lymphoma therapies, whether it was radiotherapy, whether it was further systemic therapy, an auto transplant after high dose chemotherapy, or CAR T cell therapies, which means lesser patients relapse on this particular regimen. We've also been looking for something for double expressor lymphomas. For a long time, we have known that they don't do as well as the non-double expressor lymphomas, but we've never been able to find a treatment. This again is a subgroup analysis, which gives us a suggestion that R-CHOP does not do as well in double expressor as it does in non-double expressor. But when we give CHP with Pola, this difference is kind of overcome, and the non-double expressors do just as well as, or the other way around, the double expressors do just as well as the non-double expressors when we use Pola with R-CHOP. So maybe we have something to suggest that there may be a treatment for our double expressor lymphomas in the future. The other subset that they looked at was the Asian population, and we can discuss this during the discussions. There is a progression-free survival as well as an overall survival difference for the Asian subset of patients. So we are no astrologers, but if you wish to predict or project figures, then based on the projected figures, replacing R-CHOP with Pola R-CHP as the first line of therapy will reduce the need for a second line therapy in about 27% of the patients in the next 10 years. The next 10 years will show us whether this kind of prediction holds true. But for now, definitely the NCCN guidelines has taken Pola R-CHP as category 1 and brought this treatment regimen into the first line therapy in the most recent NCCN guideline version. So the impact of POLARx trial suggests that for the first time in over 20 years, there is a meaningful improvement in the risk profile over R-CHOP in an international phase 3 double-blind randomized controlled trial. And so we are happy that we have again started moving a little forward as compared to R-CHOP. Pola RCHP reasonably accomplishes the goal of treating DLBCL patients by improving disease control, avoiding toxic and costly salvage therapies. The benefit of Pola RCHP holds importance in India with limited access to efficacious treatment of relapsed refractory DLBCLs with a, in bracket, provided the costs come down. Pola RCHP is category 1 regimen as per the NCCN guideline, which I just showed you, and is recommended by the NICE and the EMA as well. So where would we typically use this after this large randomized trial? If we have patients with advanced stage DLBCL, and of course they should be rich, stage 2 and above, with a IPI which is not 0 or 1, double expressor lymphoma, who is fit to receive R-CHOP, then perhaps Pola RCHP may be the way to go forward. For all other unfit patients for R-CHOP, we will need to use alternative immunochemotherapies in the doses and regimens that are available for them. The Pola BR versus BR alone in relapsed refractory diffuse large B-cell lymphoma has given us hope for patients who are otherwise refractory to treatment, and refractoriness in DLBCL has always been much worse than what it is for Hodgkin's lymphoma. So this is a phase 2, randomized phase 2 and an extension phase of the Pola BR with about 152 patients. And if we look at the results, the complete response rates are more than double for patients who are given Pola BR as compared to BR. And again, if we look at the duration of response, the median duration doubles when we use Polatuzumab along with BR. And this is the kind of median progression-free survival and the overall survival. And the difference is almost 2 and 3% for patients, 2 or 3 times for patients who are given targeted therapy along with BR. And these are the kind of survival curves for Pola BR, where the progression-free survival and overall survival definitely suggests there is something in this combination which is worth trying. And again, if we look at the overall survival of the randomized cohort as well as the extension cohort, definitely these patients appear to do much better than what is our own expectation for a relapsed refractory diffuse large B-cell lymphoma. Many of us have been a part of the POLARGO trial, and this is another trial where Polatuzumab has been given along with our GEMOX. And though we all have, 3 and 4 patients, needless to say that the comparison of patients who were given Pola and those who received only our GEMOX in our individual assessment has been completely different. And the patients on Pola have had a doubling of their median disease control. This is our own small experience of 10 patients, which we treated between 2019 to 2022. And this is purely because we got the drug on compassionate access and it was free for our patients. And this has been published, which was earlier mentioned by our chief guest. And so even if it is small numbers, I would encourage you all to present your small numbers because together we can make big numbers. And I won't go through the details of this, but for the sake of today's presentation, we updated the data of these 10 patients. And quite happy to see that 4 patients remain on a plateau and have crossed 2 years and a little more now. So our effective event-free survival is at 40% for these patients. Again, for relapsed refractory DLBCL. In this group, we have transplanted only 1 patient. So the other 3 actually have done well long-term without a high-dose chemotherapy and transplant. So what does the future hold for DLBCL treatment? Unlike Hodgkin's, which there is no doubt that we are going much further with the advent of targeted drugs. For the first time in 20 years, Pola-R-CHP has improved the prognosis of patients with first-line DLBCL compared to standard R-CHOP. So standard R-CHOP may not remain the standard for a very long time now. A plethora of options are available or will soon be available for refractory and relapsed DLBCL. We need to see how we are going to address the sequencing of these treatments in times to come. We've all understood that our knowledge of DLBCL was inadequate earlier. It is an immensely heterogeneous group of diseases, and risk-adapted biomarker-informed approaches is the only way to take clinical trial designs forward in the next 3 to 5 years if we want to see which drugs are effective in which subtype of patients and make a difference in the outcomes. So with that, thank you very much for your patient hearing. And I think if there are questions, I'll be happy to take them, but we have very eminent discussants and I would like their opinion on whatever I have presented.
Thank you so much, ma'am, for that wonderful talk on both Brentuximab as well as Polatuzumab. So now I request all our discussants to please put the raising signs so that we can start our question answer session with ma'am.
Question?
Yes, sir. Dr. Sasidharan, sir, you have a question?
It was a wonderful lecture, but since I have stopped practicing hemato-oncology after retirement, most of the things are new to me. But I was looking after hematology and hemato-oncology in a government medical college till I retired in 2015. And we were managing Hodgkin's with ABVD and NHL with our CHOP only. Even rituximab was a luxury for us. And the patients all belong to the marginalized sections. I would like to get your opinion, madam, regarding what you would have done if you were managing NHL in a situation like that.
So actually, I have been, I have been looking at the data both from, I was in TMH in Mumbai and then I came here to TMC in Kolkata. When we started, when MabThera came, it was very expensive. In 2007, we got the biosimilar. Soon the costs of the biosimilar were of course much less, but even the cost of MabThera came down. Around 2015, we got lots of biosimilars. And the other thing that has happened is the central government and the state government now have something like a BPL insurance. And so in most states, rituximab should not really be a problem, considering we have a patient access program, which gives us alternate cycle free. We have the Ayushman Bharat, particularly in West Bengal, we have the Swasthya Sati, which gives about an insurance of 5 lakhs to patients who are below the poverty line. And since 2019, there is no patient in our institute, and I think across many institutes in the country, where we are not able to give rituximab. So most patients now would get rituximab. I agree, till 2010, we were struggling. We had about 50% of the patients who would receive CHOP and 50% who would receive R-CHOP. That number changed to about 70% in somewhere around 2015 when many rituximab biosimilars came up. And after 2018, I think I feel comfortable that I have not been able to send away patients, nor do I not give them if it is indicated. So we have NGOs, we have lymphoma foundations, we have money coming in from access programs, and we have money coming in from the governmental agencies. And I think today it should be the same. Like you, even I'm going to retire shortly. And I feel it's such lovely times to be in the treatment and management of lymphomas. And I think both of us are going to miss that. But it's been great being able to see the change at least.
That's true. One particular question that we face in India, because we do not have strong primary care, where do you send your patients for follow-up after chemotherapy during that interim period before they come for review?
So this is a problem in big tertiary hospitals, which are regional cancer hospitals and the institute like Tata Memorial Hospital, Mumbai, where we used to give the first cycle of chemotherapy, and most patients would have to go back, and then we would have some of our students, some of our known people in various parts of the country, and send them there for further treatment and continuation of their treatment. I think when we work in these trust hospitals and a little more private and corporate hospitals, that problem reduces. Either they don't come to us for treatment and go away after taking a second opinion, or they continue the entire treatment over here. And during follow-up, we are comfortable, if they follow up with their primary physicians in whichever state or town they come from. And with Corona coming in, the telemedicine has come in a big way now. So most of these patients, we are able to follow up without calling them to the center on a teleconference. So that is something I would encourage everybody to do, because follow-ups are important. And if we have patients questioning us on WhatsApp, it never gets entered into the hospital follow-up. So if you have a teleconsultation, the entire follow-ups of the patients remain. They don't have to come every 6 months or every year for 5 and 10 years. And like you mentioned, the data keeping is so important. It helps in generating, foolproof data as well.
Still, more importantly, if we had a strong primary care with trained primary care doctors sitting in the periphery, this would have been easier. But somehow we are missing that.
Yeah, I think the first state which is making an attempt at that is Assam. They have 3 levels of oncology care, and that is supported in a large this thing by the Tata Group. And if that is a successful model, then maybe many other states will take. But it's going to be for the next generation to take that.
That's true. That's true.
Yes.
Thank you, ma'am.
Thank you, sir. Dr. Sadashiv, good day. Your question, please.
Good morning, madam. This is a wonderful talk. I think the journey of this lymphoma treatment over 2 decades, I think we are the part of this. Again, our RLYMPH study is published our data from India. I think in that time also, not more than 30% of the population, they received this rituximab. It was a standard of care. So I think as we nowadays, we have many government insurance programs where they can provide this rituximab at free of cost. In our state, I think we are able to give all lymphomas with rituximab-based chemotherapies, including transplantation also we are able to do under this health insurance program. Thank you once again for a wonderful talk. My just one question is, where do you place this polatuzumab in front, madam, in DLBCL?
So if I have to say honestly, in our whole team, I think we have given it to 2 patients upfront. And obviously they have to be rich, number one. It was very expensive. Now the costs have come down a little bit, so we can still think of it. But otherwise it was, I thought I'll leave it for the discussants to, actually take a call on it. Because definitely there is a 6% PFS benefit. There is no overall survival benefit, but the Asian community has shown an overall survival benefit. And the reason why they feel that benefit has been shown in that subgroup is because the second line treatments are not very easily available across Southeast Asia. And so it has a meaning if the costs come down. My own choice at the moment is, of course, besides the wealth, it is a patient of stage 3-4 disease with a reasonably higher IPI, preferably in patients who are ABC type, because again, in that paper, if you see in the subgroup analysis, it hasn't shown too much in the GCB. So if I have to give it, it will be for a double expressor patient. And yeah, I think those would be my considerations. Obviously, not the very early IPI. It should be 2 to 5, preferably 3, 4, 5 as the RIPI. These are the patients whom I would consider for Pola in the upfront setting, or at least I would give this group of patients a choice to choose from: Pola, RCHP versus RCHOP.
Thank you very much.
Thank you, sir. We have some questions from the audience, ma'am. Doctor,
Into the chat box.
Yeah, no, I just read it out to you. There's some repeats, ma'am. One question has come from Dr. Chandrakant MV. We have all the 3 drugs in India now, that is Pembro, Nivo, and Brentuximab also, in addition to AVD for use in the first line treatment instead of ABVD. If we decide to use which drug to choose, any specific recommendations or indications to prefer one over other?
Okay, so my disclaimer was I have very little personal experience with these. Everywhere it is 3 patients, 5 patients, at max 10 patients. So young patients with stage 3-4 Hodgkin's lymphoma who have extranodal symptoms or extranodal areas of disease, I would definitely consider something beyond ABVD for them. We have been thinking in terms of escalating to BACOP, but all of us know how tough BACOP is in our setting and how much more costly it becomes. Patient is admitted for most of the time. So Brentuximab definitely is my choice over there. When I've used Brentuximab with AVD, it's not very easy for 2 reasons. One is the peripheral neuropathy, and the painful peripheral neuropathy is quite a bit even in very young patients. So you have to constantly be watching them. It's not as easy as giving ABVD and seeing them once in 15 days. Some of the patients would get admitted twice in those 15 days, either with very severe pain or with febrile neutropenia. So growth factors is an absolute must in these patients, which also doesn't add on too much to the cost in India, but rest of the world or rest of the countries, it does add on a lot to the cost of treatment also. So I am careful, but I use it in young patients. In older patients, I prefer to use Nivo because it is a little more easily tolerated. The toxicities are less. But then you always worry about the checkpoint inhibitors and their cytokine release syndromes and the ICANS. Haven't seen them, but again, I have only 3 patients. In anybody who has a CNS affliction, like there was a patient who came with some CNS symptoms, turned out that he had some kind of a meningitis at presentation, but I would be hesitant to use Nivo in those patients, so I would use Brentuximab. So these are, a little bit of clinical work and clinical experience of seeing various patients that I can suggest. But I think we will need to wait for the long-term results of the SWOG trial, which is actually Brentuximab versus Nivo. And once we have 3 and 5 years outcomes of that data, we will have a much easier time in choosing which drug for which age group versus what comorbidities versus what outcomes to look at.
On the same note, ma'am, any talk on about low dose nivolumab?
Okay, that is an Indian expertise. Everything we make low dose and we succeed. So I think that is something somebody suggested. We should first keep our data of all these, like we have kept for the last decade, we kept all DLBCLs, all Hodgkin's, at least in 9 centers. We now have so many centers which have an EMR. And the real world data is something which is so easy to collect, even retrospectively, because everything is recorded there prospectively. I think we should have registries for these targeted agents, have a baseline, and then go into at least a phase 2 with low dose and see if it matches. I'm not recommending a full-fledged double-blind randomized trial of any of these things. It's not possible. I have burned my hands in my young days trying to do randomized trials, and I understand that that is not possible with the kind of funding that is available for trials. But definitely real world data, real world evidence is something that we can do. We've done it for the last decade and we've done it with success. So I think that's the way forward for all these new drugs also.
Thank you, ma'am. Dr. Chandrakant, you have put some questions in the chat box. You can ask yourself.
So, ma'am, good afternoon, ma'am. It was great listening to you. So, thanks, ma'am, for spending your time. So, ma'am, is there any role of escalated BACOP if a patient can afford these good drugs? I think it's very difficult to use that. So, we shouldn't be talking about escalated BACOP in the present day, ma'am. What is your take on this?
In the past also, I never spoke of escalated BACOP. I remember the German Hodgkin study group founder, Dr. Woker. He had come down and he was so insistent and he tried to argue me into BACOP. And, all of us work in, let me say, institutes which are already overworked, and our logistics just doesn't allow us to admit more febrile neutropenia patients than we already have. And escalated BACOP is no joke. So instead of actually increasing the outcomes at 5 years by 4, 5, 7, or even 10%, we would lose induction, and even 4, 5 patients lost during induction would, kind of not justify the results. So we never actually moved to BACOP for that matter. Escalators was another thing. More recently, we were tempted after the Rathel trial for patients who were in partial response in the interim PET scan to go on to escalated BACOP. We have treated about 7 or 8 patients with escalated BACOP changed after 2 cycles of ABVD. But we had lots of toxicities in these patients, and we were never able to give the doses and maintain the intensity of treatment. And so I'm not going to say that our results were bad, but it was a struggle for these patients. And so in our own setting, we have taken a kind of a decision that if somebody is in partial response at the end of 2 cycles, we'll continue for another 2 cycles. And if they still remain in partial response, the easier way to go is Brentuximab, bendamustine, and autotransplant. So you don't give too much of the newer drugs. You give them the salvage and you salvage them and give good results, because that is something which has shown us long-term results in patients who were relapsed refractory. And these are actually patients who have had a partial response. So I would expect them to do a little better than what we have been able to show in relapsed refractory disease. So the short answer is no, I am completely out of escalated BA-COP.
No, that was really insightful, ma'am. Like, you shouldn't even think of it unless it's a real requirement.
Unless, really you can't afford Brentuximab, you can't have auto transplant. And the cost of all of that is now not much more than the kind of supportive care you will require with one febrile neutropenia is enough to
To drain
deset.
everything out. Yeah. True. Ma'am, if in the salvage regimen, if your intention is an auto transplant, and if I have to use a targeted therapy, there I would prefer Brentuximab over the immunotherapy molecules, as a bridge to transplant, because if they cannot do auto, then allo. So there is some interference of IO with the allo. So how do you think
You,
these molecules, ma'am?
you need to give a reasonable washout time after you have used the checkpoint inhibitor, and that kind of a washout time may not be the best thing for somebody who has a refractory disease. So we have been comfortable over the last so many years with Brentuximab bendamustine as a combination. We have failed with Brentuximab bendamustine. In that case, we go ahead with Nivo. And then, of course, we do take them up, but we take them for a delayed transplant. We don't take them up for an allogenic transplant immediately because these are candidates who go for allogenic transplant.
Thank you, ma'am. Thank you so much.
Thank you, Dr. Chandrakant. We have some question from Dr. Sinwin. She wants to know, she has a case of 14 years old boy, anaplastic large cell lymphoma, stage 4B, given Brentuximab plus CHP 8 cycles. Anything else to be done now?
So ALCL, it will actually depend on whether it is ALK positive or ALK negative, and also on the stage of the disease, early versus late. If it is ALK positive, early stage, I think nothing else if the patient is in complete response, because they are good and their outcomes are just as good as DLBCLs. So we have a reasonably good first line treatment, and we don't go for consolidation with high dose chemotherapy and transplant. Now, if it is stage 3 and 4 and it is ALK negative, then at the end of therapy, even in the echelon study, there is reason to believe that those who were consolidated with high dose chemotherapy and transplanted did a little better. I think I will recommend that she should go through that paper once again so that she can understand what is the difference. It's not a very great difference, but definitely it is something to think about. And I would recommend in a 14-year-old child. If it is stage 3, 4, and it is ALK negative, yes, try to think in terms of consolidation and go through the paper before you do it. Because I'm not really good at handling kids. I can handle anyone over the age of 18 years.
Thank you, ma'am. Another question from Dr. V.A. Arun. Do you think PFS 24 is a good surrogate for OS in randomized controlled trials for lymphomas for both the drug trials, approvals, and real-world practice changing algorithms?
Okay, this is too long. So let's do one by one. One is PFS 2 years.
PFS 24, yeah.
So PFS at 2 years gives us a reasonably good idea of what is going to happen, because in most of our experience, the largest number of patients who are going to relapse will relapse at 1.5 years. So 2 years is, a reasonably good time period to start thinking. That definitely a good surrogate, no doubt. But if you see in everybody's experience, there are patients who continue to actually relapse one at a time. And that goes on not only till 5 years. Recently, we've seen patients 10 years after our job have come back with the disease. So whether it's an absolute surrogate, no. Then there were another part of this question further, if you just read that.
So for both the drug trial approvals and real-world practice-changing algorithm, should we make it on the practice-changing algorithm based on the PFS 24?
I'm beginning to become comfortable with real-world data for 3 reasons. One is the data quality has to be good, which means you just can't collect the data of the few patients who have come to your clinic. It has to be prospectively kept. The denominator has to be stable. It can't change. And you can't say that, the patient's files are missing. That all has stopped now with the EMR. So every institute which has an EMR is able to keep data. Where we are still struggling is with the follow-up data. So if we have mechanisms where we will get follow-up data for 5 and 7 and 10 years, then I think the real world data will make real sense. Because in any clinical trial, you take patients and you include patients who are really good. So no, myeloid series are very good, bone marrow is very good, kidneys are very good, liver is very good, patient is very good, PS. In real world, that doesn't happen. Every Tom, Dick, and Harry walks in either on a stretcher or on a wheelchair, and you have to accommodate him. Many of these actually get cured. So I think the real world is going to give us much more meaning, provided we, like I said, keep it well. We keep the data prospectively. We can analyze it retrospectively. And this, the suggestion from our chief guest today was that please put your data together in any group, but keep it together, because as an institute, you have 100, 200 patients. In 9 institutes, we have over 1,000 patients of Hodgkin's, over 2,000 patients of DLBCLs. I think that is fantastic. Imagine if we were 20 institutes or 29 institutes like the Rituximab data. We had, in 4 years, we had more than almost 1,400 patients. So very quickly in India, we can have very good real world data. All that you need is EMR, a data, what should I say, a software which records for all. And that is an interface where we will still need to get our coordinators to put in the data. But as AI and machine learning comes, I think that problem will also get sorted. But let's not wait for AI to take over all our work. Let's get started with the real world data. I have great faith in real world data.
Thank you, ma'am. Another question from Dr. Bilal. He has a young fit patient of double hit lymphoma, stage 4. Your choice between R dose adjusted epoch versus Pola R chip.
So really, Pola R CHP, there is not much data to be absolutely confident. Whereas with dose adjusted epoch for the last 5, 7 years, we have been comfortable. And for double hit lymphomas, we have now all patients, some of them are long-term survivors. So at the moment, if I have to treat somebody, it will be dose adjusted epoch. I may think of adding Pola, but I'm not doing it as of now.
So if the patient is double expressor lymphoma here, then what your take on Pola R chip?
So double expressor, if we look at the paper, which is the randomized study, at least in a subgroup they have found. So subgroup is always hypothesis generating. We need to actually again do the same thing in a real world, put all our double expressors together and see those who we are treating with R-CHOP versus those who are treating with. So if we have 20 centers, 2 years later, we'll have the answer from here itself.
Thank you, ma'am. Another question from Dr. Suresh Sanchiti. What is the cost for 6 cycles of Pola R chip in India, and any support group available for the same?
Yeah, now I think for every 2 vials, they are giving 1 free. It is coming to approximately 15 to 20 lakhs. Earlier, 1 cycle used to cost our patients 10 lakhs. So we actually never got, I think we treated only 2 patients on that, and that also was in the resistant relapse disease. Now it has come down. If I'm correct, you will be able to complete your treatment in about 25 lakhs.
Perfect. Another question from Dr. V.A. Arun. In relapsed DLBCL patients, Pola was avoided in transplant eligible patient as salvage therapy. Do you think upfront use of Pola in DLBCL patient can reduce their bone marrow reserves for autologous stem cell transplant or even CAR T cell therapy?
That is something, I don't think I should comment because I really don't know the answer. We'll have to be careful, but we need to generate the data as well. This same fear was there when we were using Brentuximab and Bendamustine. And we've not really had problem in mobilizing patients. When we use Bendamustine, we are always worried. And then on the top of that, it was Brentuximab. But we did not have problems in, so it's keeping our data that has given us the kind of what should I say, confidence today that we treat everyone with bendamustine, Brentuximab, we mobilize them and we transplant them. And a majority of our patients actually undergo allogenic transplants. Autologous transplants. The only allogenic ones are the ones which are really resistant to these. Those are the guys who undergo allogenic. Otherwise, we take everyone for an auto transplant. So if we have managed with those drugs, I'm sure if we keep the data here and see, we will be able to take these patients forward. If you look at the combination of Brentuximab and Nivo in Hodgkin's lymphoma, relapsed and refractory, and I did show that a large number of them have undergone transplant and their outcomes are at 90%. So obviously they have all been mobilized with both the groups of these drugs.
True, ma'am. Another question from Dr. Roshni Bhagwat Pandey. For 65 years old Hodgkin's lymphoma, stage 4BX with left ventricular dysfunction and abnormal pulmonary function test, the medical insurance does not cover for Nivo and BV. What would be the most suitable first-line option for this patient?
So first, hi Roshni, so nice to have you on board. Okay, so no, I mean, she has put me in a soup. So there is almost nothing that I can do except suggest what we did together in TMH. And I will tell you, COPP is not a bad drug for old patients. It has a reasonable response rate. We don't have to worry about the toxicities and long-term toxicities in the young patients for somebody who's over 65 years. And I wouldn't give up this patient completely. The second thing is bleomycin is something that we commonly avoid after the age of 70. Adriamycin goes out for a patient who is got congestive cardiac failure and poor ejection fraction. So if you have to use a combination of drugs, it is CEOP. Many of the Hodgkin's lymphomas are actually CD20 positive. So I may actually go one step forward because rituximab at least is a very safe and effective drug, and we have seen it over years. And we have used it both in lung compromised and in cardiac compromised patients. So if it is a CD20 positive classical Hodgkin's disease, I may also take the help of rituximab. So RCVP, CEPP, COPP, and I would go back to all the knowledge that we gained in the first few years at TMH.
Thank you, ma'am. Another question from Dr. Bilal. Your data on Polatuzumab in treatment of HIV negative plasmablastic lymphoma.
Okay, the Polatuzumab data of our 10 patients is largely DLBCL. There's one primary mediastinal and there is one more. I don't think we have actually looked at HIV positive patients. And the thing is, HIV positive patients have to be treated exactly like you would treat the HIV negative patients. With the new drugs, we may have to be a little careful, no doubt about it. But the dictum has always been treat them just as you treat your HIV positive patients. I don't have personal data with Pola in an HIV positive patient.
So the question was on plasmablastic lymphoma. HIV negative plasmablastic lymphoma, Polatuzumab.
Okay, so unlike rituximab, which is a CD20 molecule, anti-CD20 molecule, Pola acts across all B cells. So it's a valid point, something to think about. And definitely, if I have a plasmablastic lymphoma, I will think about it next time, but I haven't used it. But I think it is very meaningful, the question, that if you have a B cell lymphoma, which is a B cell across, obviously the very mature B cells also should respond. And this would be one of the things to think about.
Thank you, ma'am. Another question repeat question from Dr. Roshni Bhagwat Pandey. Your experience on low dose Nivo. So
don't have a low dose Nivo experience. So, and I have experience, let's say again, another 5 patients whom we have put on Nivo with AVD upfront, and some patients who were not responding, we have used Nivo and Brentuximab, but we've used them in patients who had financial support. And so I've always used them in the doses that are correct doses as recommended. So I won't be able to answer that, but I will tell you some interesting facts about these patients who were elderly, who are on Nivo and Brentuximab. They go into remission and they come in very terrible condition. They have been resistant to almost everything. Their general condition improves. They come out of ICUs. They're able to take the treatments. They also become well enough to start walking. They remain under control for a long time. When the PETs were negative for some time, we decided that Brentuximab will now start causing peripheral neuropathy in an older patient with comorbidities. So we took away the Brentuximab. After some time, we realized the PET shows increasing disease on Nivo, and we put the patient back on Brentuximab, and she's in remission again. So I don't know how these drugs work, but they do work. Some principles of oncology, which we would say progressive disease, why are you continuing the same treatment again? But they do go into remission. So interesting drugs. We should try the low dose Nivo. We should try the low dose Brentuximab, and there is evidence, or there is a paper actually published, which comes from the Echelon trial, which is a sub-study. And in that, they realized that the peripheral neuropathy with Brentuximab was too much for many patients to take. And so they had to cut down on Brentuximab. Some took it for, they've given 3 doses. One is the full dose, one is maybe about 25% less, or within 25% to full dose, and the third dose group is even less than that. And if you look at their outcomes, there is no difference in the outcomes of these 3 groups of how much ever Brentuximab they could use. That means the dose of Brentuximab did not impact the outcome of the AVD. So I will, for anyone who's interested, I will send you the reference. Which gives us an idea that the doses we are using are quite high, and there is definitely scope for reducing these doses and treating patients with lesser doses with the same outcomes. But that will have to be done in a controlled manner, whether you do it as a phase 2 run or we do it in a regular randomized trial. It needs a lot of thought before we start putting patients prospectively and then look back at the data. But to say that these drugs can be used, the proof of the pudding is there in that paper, that in 3 doses that they were able to give patients according to toxicity, the outcomes are not different. So there is definite meaning in these questions.
And when your talk on duration of Nivo maintenance in Hodgkin's lymphoma post-BV, post-transplant relapse?
Post-BV, post-transplant relapse. Nivo, then I would, if I have to give Nivo and the patient goes into remission, my own suggestion to them is to continue as long as the patient is in remission.
I finished the question from the chat box, but Dr. Deep Gala, your question, please.
Thank you, ma'am, for this wonderful overview. Ma'am, I had 2 questions actually. First is, ma'am, does reducing the frequency, making Brentuximab once in 3 weeks rather than once in 2 weeks, reduces the incidence of peripheral neuropathy, ma'am?
So yeah, the Brentuximab dose also can be reduced, and the interval also can be changed. The ideal dose when you use Brentuximab 3 weekly is 1.8. So you can use 1.2 if you have to reduce the dose. And the peripheral neuropathy at least remains stable for some time. It actually goes away only after you stop, and it takes quite some time to go away. So peripheral neuropathy is a definite problem. Not so much when you're using 3 and 4 cycles in the bridge to transplant, but definitely when you're using it every 15 days in AAVD regimen.
And ma'am, another question was for a 20-year-old male who had received case of relapsed Hodgkin's lymphoma, received salvage with Brentuximab plus Nivolumab. After that was transplanted and has disease relapse 2.5 years after transplant. So ma'am, what should be the salvage at this time point
Somebody
Can
who's
we?
relapsing after 2 years, generally in the good old days, the dictum was you can again retry with the drugs that they were responsive to. So you can again retry with the same drugs. Sooner or later, CAR-T facilities will be available, and we will also have to start thinking in terms of alternative therapies for these patients. But if it is 2 years later, I would be comfortable to re-challenge with the same and then take up straight for allogeneic transplant. After that, till CAR-T is not available over here.
Yes, ma'am. And ma'am, what group of patients post autologous transplant would you suggest giving Brentuximab maintenance, ma'am? Will it be given to all the patients, or will it be specific subgroup of patients?
The more high-risk patients which we took for transplant, the ones with extranodal presentation, generally Hodgkin's doesn't present so much with extranodal. Those are the areas where we would take. Having said that, the trial at least shows across there is a benefit even at 5 years. So if someone can afford it, then I would recommend it. I think now things will become better. Brentuximab is much more easy to get. Nivo is much more easy to get. There are access programs available, and hopefully we will have a generic Brentuximab also coming up, and so things will get better. In the next 2 years, I think everything that I said about reducing the chemotherapeutic drugs and moving on to targeted therapy will be a reality for all of you.
Thank you, ma'am.
Thank you, Dr. Deep. There is a question from Dr. Bhuvesh Vannath Gauri. Would you kindly tell us about any India-specific supportive care medications and whether the rates of infection differs from the West, and any data on CD4 count recovery?
So the infections in India is a real problem. And in tertiary hospitals, the MDRO and the deadly infections is, so now I am scared to admit my patients. As much as treatment which can be done in the outpatient should be the dictum for the oncologist. So even if your hospital says you have to show so many admissions under you, try to avoid, because your patients are going to live much longer if you don't admit them. So I don't know how we are going to solve that problem out. Having said that, all these drugs can be easily given at the outpatient. Many of them are now becoming subcutaneous. And so as much treatment in the outpatient as possible. We have MDRO infections in almost 30 to 40% of our patients. They require the third generation antibiotics. There is, they come out of the acute infection, but they lose the dose intensity, and we are not able to complete their treatments, and their results obviously are hampered completely. So infections are terrible. Infections have to be managed and have to be prevented rather than put patients into the ICU, struggle with them for 35 days, bring them out, and then have the disease coming back. Regarding CD4 counts, I don't do it for everybody. It's only in the HIV positive patients. When we start treatments, the only thing that we look for is if CD4 counts are very low, then we avoid giving them rituximab immediately. And we add rituximab as and when their HIV status comes under control and their CD4 counts increase. And the number of cycles that we have missed in the first 2 months of treatment, I normally add them at the end of treatment, like, you give 6 cycles of R-CHOP plus 2 cycles of rituximab alone. So I complete the amount of rituximab once the CD4 counts have normalized.
And any supportive care medications along with BV and Pola with these new therapies?
So with Brentuximab,
prophylaxis.
So if we see the combinations, they still have prednisolone in high doses. So we do continue to give them Septran prophylaxis. We give them Acivir prophylaxis. We give it in the lower doses, not the 800 or the 400, but 200 milligrams BD. And if they are HBsAg positive, then of course we give them the antiviral prophylaxis also. So these are the prophylaxis. I don't give antibiotics as prophylaxis because we already have terribly resistant bugs. And giving them any kind of oral antibiotic as prophylaxis is going to end up with worse infections when they actually get one. So I avoid, other than Septran, I avoid everything else. And Septran is once, 2 times a week, not more than that.
Thank you, ma'am. Dr. Hitabi has a question. NLPHL early stage and advanced stage disease, your regimen of choice.
So very early stage, if you have removed the node, you can keep the patient under observation. So single node, excision biopsy done, you don't need to do anything. If it is a localized disease, then only radiotherapy is good enough. You don't really need to give them chemotherapy. And if it is disease beyond the loco-regional control of one field of radiation, then we like to give them chemotherapy with rituximab. So it is a CD20 positive lymphoma, and it appears to, I mean, there's really no randomized trial again to say that rituximab has made a difference in NLPHL, but the numbers are so few that we'll never get through a randomized trial. And so, just logically thinking it is a CD20 positive lymphoma, so we give CD20. Regimen can be of your choice, whether it is rituximab alone. If it is not a high volume disease, it's an elderly patient, it can be R-CVP, it can be R-CHOP, it can be R-ABVD. Whatever you choose as your first line regimen is quite fine for these patients.
Thank you so much, ma'am. And last question is, 20 years old DLBCL, GCB subtype, would you choose pediatric regimen or R-CHOP or Pola R-CHP?
So 20-year-old, I am most comfortable with R-CHOP for them. So I would not use the very intensive, aggressive pediatric regimens. And I would even encourage the pediatricians to start reducing the age to 14 and maybe 12 to see if R-CHOP is, because it's so easy to give. And like I said, if you can avoid admitting your patients in an oncology center, you are doing great service to them. So anything that will keep them away from infection, and R-CHOP is completely an outpatient regimen.
Thank you, ma'am. So I finished all the questions from the chat box. Any discussion want to ask any other question to ma'am? Well, so ma'am, there are no more resin signs, and
for your patience, I was admiring your patience.
thank you, ma'am. It was so fantastic, so wonderful. And what a wonderful explanations you gave to all our questions. Maybe some were repeats and some were very easily. We were confused with so many, points, and you really brought out so nicely here. Thank you, ma'am, so much for your wonderful lecture, wonderful discussion, wonderful question answer session. And I thank all the audience over here as well as discussants to participate today once again. And I thank Roche for participating and sponsoring for this event. Thank you so much once again, ma'am. And thank you all the discussants and audience. Join you next week with another beautiful webinars. Thank you so much once again, ma'am.